Right. So good evening, everybody, and welcome to the DY Patil Postgraduate Psychiatry Knowledge Series. We have another exciting talk today with a distinguished speaker and an equally distinguished person to chair this session. Dr. Alka Subramanyam, I have known her for many years. I think though she probably got into Nair way after I left. But then we've interacted enough and we've grown to uh, know each other on various forums at various opportunities and for different reasons. And she is a very astute teacher, a very well recognized person in the area of child and mental health, and a very nice person, very warm person, very accommodating, very open-minded, and that's one of the qualities of her that endears her to a lot of people. Uh, and I will allow Dr. Jairam to do the honor of introducing her to all of you. Dr. Jairam, I've known him for a few years, and I was very impressed by how astute yet so humble he is, and a very, very simple, down to earth kind of a person, very approachable. And that was something that clicked instantly for me. And he has been a part of the academic activities that I have been trying to put together. And unequivocally, he's been supportive. He's been there every time I have requested him to join us. And he's very, very gallantly agreed to chair the session today. And I cannot think of a more apt person to chair this session than Dr. Jairam. Dr. Jairam is a consultant psychiatrist. For those of you who may not know him, I'm sure there are very few of you who may not know him. He's a consultant psychiatrist at the Apollo Multi-Specialty Hospital at Kolkata, and he's the founder director of the Mental Health Foundation at Kolkata. After completing his MD from NIMHANS, he was in the UK, which he was just telling us about, and he did his MRC Psych and CCST and Child and Adolescent Psychiatry. He was working at the West Yorkshire as a consultant child and adolescent psychiatrist before he came back to Calcutta. His areas of interest are autism spectrum disorders, ADHD, psychosis in children, and child sexual abuse. He's been a part of a large epidemiological study of prevalence of autism in Kolkata, which was published in international journals and is currently a part of an ambitious statewide autism screening project in West Bengal, which aims to train more than 1 lakh Anganwadi workers. He works with a multidisciplinary team of 16 professionals and has been organizing workshops on ADHD and ASD in Kolkata for many, many years. So, welcome, Dr. Jairam, and thank you so much for making the time. And I hand over the proceedings to you, and I shall step back in right at the end of the day. Over to you, Doctor.
Thank you. Thanks. Thank you, Rashmin. As always, it's a privilege to be part of this, and I really admire the tireless zeal with which you do this, continue to do this, and thank you once again. So I believe, for those who are listening to today's program, and if you haven't heard of Dr. Subramanyam, you must have been living in a cave, really. She is really a force to reckon with, and I also admire the clarity with which she speaks. And every time I hear her, I pick up something new. She is an associate professor at TNMC and BYUL, the Nair Hospital in Mumbai. And she has been awarded the Hardopin Fellowship in 2007. She has, a number of awards and years of experience of more than 2 decades. So, but what I like really about her is the clarity with which she speaks and cuts to the chase, and never gets flustered when other people speak a lot of nonsense. So that is a quality which I I have to pick up from her. Over to you, without wasting much time.
Thank you so much. Thank you so much, Jairam and Rashmin, both, for those lovely words. I'm not sure I really deserve them. And it's honestly, with you in the chair, I have to really think of what words I'm going to be using and how I'm going to go about it. But it's always a pleasure being a part of this series. And like Rashmin reminded me that, come on now, it's your turn. Buck up. I almost tried to chicken out of this one because I had something to do this morning, but finally we are all here and together and talking about a topic which is very close to my heart. So, okay, I'm not sure how, has this come on? Can you see the screen?
Yes.
All right. So today we are going to be talking over the next 45 minutes or so about recent advances in ASD. And because they're recent advances, we're not really going to go into a lot of the basics. We'll just try and have some case-based discussions. So what I'm going to attempt to do is actually discuss a few things. And when I'm throwing out the questions, I request you to answer in the chat box. I'm not sure I will be able to, okay, let me try and see if I can join in on another device and answer the questions. Otherwise, I might need help with at least the questions which are
I
asked.
can follow the chat box.
That sounds super.
Yeah.
Thank you so much. Okay, so now first, let's just begin with a quick recap of what our understanding of autism is. What are the key symptoms of autism according to y'all? Please type your answers in the chat box. Has there been any change in the key symptoms according to you? Do we have answers coming up? Yes.
Yeah. So there's asociality is one of the answers. Yeah.
Anybody else? Come on, guys, type in the chat box, please. Lack of social interaction and communication. Very good. Any other features? How many do you think? Repetitive behavior, restricted, poor social, hyperactivity? Excellent. What has changed in the past? What was there and what has changed now?
So there are quite a few: repetitive
Yes.
behavior, language. Yeah.
Okay. So I think we've got quite a few answers. Right. So the core symptoms when we had DSM-4 were 3, which all of you in different parts have kind of outlined. That is social impairment, speech communication difficulties, and repetitive or restrictive behaviors. What DSM-5 has done is sort of clubbed social impairment and communication into one and made it social communication deficits along with the restricted or stereotypic behaviors. And therefore, this has widened the spectrum of autism. So we have many more children who are coming under the ambit, and therefore that spectral concept is actually achieved when we have changed the criteria to make it so. It's not that we don't have to follow the criteria or we've actually changed too much qualitatively. But if we had to stick to what was given earlier, then there were many children who were sort of on the gray zone or the borderline, and they were not getting help. Because you see, in our country, you have to hunt for help yourself, just like we were discussing for those of you who joined early on. But in other countries, the state funds it, and they will not fund it unless you get a diagnostic label, which is why they run more after the diagnostic label and we run away from it, so to speak, right? So the other thing that changed is that we don't have compartments or categories for ASD, like Asperger's, childhood disintegrative disorder, or REDS. Everything comes in a single nosology or the spectrum. So keeping this in mind, let's try and understand a few things about what is recent advances or what are things which are coming up now, because this is a multi-million-dollar research field. Unfortunately, we don't have those dollars, but we still try and do research in our own little way in India. But what is happening around and what are we clinically seeing is what we're going to discuss today. All right. So none of these patients are real, just a disclaimer to that. So our first case is Mr. Bartley Boy, who was a 49-year-old man who approached us as his son was advised to undergo autism evaluation by the school. During the process, he himself felt he had similar symptoms and should get tested. He further revealed having a strained relationship with his wife, who said he was emotionally distant. She stated that he was good at his work, but a loner. Further, he was quite a miser, and every penny spent had to be accounted for. He stated that he loved his wife and children, but rarely felt the need to express the same. He was a workaholic and didn't ever feel the need to socialize or spend on frivolous things. What do you think is wrong with Mr. Batley Boy? First of all, do you think something is wrong with him? If so, yes, what? And does he need any intervention? Please write your answers in the chat box, so I can actually see the chat box now. Yeah. Please write your answers after reading. Broad autism phenotype. Very good. Anybody else? First of all, do you think there's something wrong with him? Yes or no? Let's get yes or no answers first, and then we'll go to the next. Yes. Anybody else? Yes. If anyone thinks no or doesn't know, please type in the answer. Okay, so if you think something is wrong with him, Tony Thomas has written broad autism phenotype. What do you think is wrong with him? Is he on the spectrum? Is it some other spectrum? Is it just the personality? Do we really need to intervene? He's having a successful job relatively. He's married. He has 2 kids. Difficult one, chairperson. Well, some OC symptoms, no intervention needed probably. Cluster A, PD, very good. Okay. Anybody else? Probably no intervention, yes. Anybody else?
Can I answer also? Share my thoughts?
Of course, please.
I think with his consent, maybe I would like, explain his nature to his wife and children, because they might be wondering what is happening. What is this whole person about?
Right. Absolutely. So we'll go on now. And what is interestingly found in families, and we are finding this is what I nickname to our kids here as reverse genetics. But what we are finding largely is something called as an autistic endophenotype. So when you're looking at the entire spectrum, or you're looking at a family, you would find certain traits to exist in the family, which are otherwise missed because they have been supposedly functionally normal, right? When you go back, this individual was intelligent enough to say, listen, I am like this, and nobody has picked me up before this, right? But what we find when we deal with families is sometimes you would find one of the parents is more difficult to penetrate through, or has repetitive questions, or has what looks like OC behavior. And when you really go back into the history from childhood for the parent, and you find out that there's certainly this trait or this autistic endophenotype which is there, which did not manifest in that generation. And since it has been transmitted on, and how does it get transmitted? So this looks like a very busy slide, but just walk with me through it. So initially, at the time of conception, there are so many issues. Particularly what we focus on is increasing age, multiple abortions, or issues with the HLA haplotypes. Then issues during gestation, which is like hypertension, diabetes, autoimmunity, other inflammatory conditions, and later, which could lead to problems in later gestation, which is again risk factors or inflammation or autoantibodies, which you would not come to know at that point in time, right? Once the baby is born and in early childhood, there may be comorbidities or susceptibility to certain neuropsychiatric disorders or markers. You might find soft neurological signs emerging. And once the child reaches adolescence, the person reaches adolescence, you find susceptibility to either psychiatric or autoimmune disorders. And this is a loop which loops itself again and again and again. And therefore, you find this transgenerational shift, or that autism endophenotype what Tony said to be a broad autism phenotype, what we call it as. So in the generations, we would find it. So when you're looking at children with autism, I would strongly urge and encourage you to look at the families too and see whether you're able to trace this. It's not easy and you may not get to do it immediately, particularly if most of you are in private practice and you don't have that kind of time. Therefore, you can split it up into various sessions. But once you get used to this, you will see that there is this kind of pattern which is emerging. And therefore, when we are working with the family, we have to keep this in the back of our mind, because this may be a limitation of one of the parents where we are not able to penetrate even something as simple as psychoeducation or their acceptance of certain traits of the child, which is why I thought it was important to discuss this right at the outset. And of course, this is the development of the child and how the change occurs in autism or in any other neurodevelopmental disorder. So now that brings us to case 2. Anjali is Aryan's mom, and Aryan was diagnosed with ASD at the age of 4. She's done everything possible to help him cope with his autism. She and her husband, both doctors, had decided not to have any more children. She discovered last month that she conceived, and it was totally unplanned. She does not want to undergo an MTP, thinking that this is an act of God, but wants to know how early she can diagnose the younger one, if at all. How early do you think she can diagnose? Okay, for some reason that chat box has disappeared. Okay, let's come back again. 5 months. Okay, why do you say so? How do you diagnose at 5 months, Meghna? Anybody else? How early can we really diagnose the second child, and how do we diagnose? Social smile, okay. So social smile, when do you expect it to come and when does it not come over here? Eye tracking, excellent, Dr. Jaya. Some of them have heard. This is something which I reiterate in every talk on autism because I think it's so important. Okay, so people have got that absolutely bang on, that eye tracking. Do you know when, what age group we are looking at eye tracking? How early? So we had path-breaking work done by this group of researchers at Atlanta. And what they were able to find is between 2 to 6 months of age, eye gaze patterns can actually determine which of the babies can, go on towards the autism spectrum and who are going to go towards the normal spectrum. So if you look at this is not very clear, but please focus on the red. And this is a child who's been tracked, who eventually developed ASD. And this is one who was neurotypical. And you can see that there is a focus towards the eye. We'll see some more images soon too. So this study focused on 110 infants, 59 of who were high risk. When we say high risk, they were like Aryan in the case that we discussed, where they already had one child, an older sibling on the spectrum. And they tested each infant 10 times between the ages of 2 to 24 months, all right, just to see the level of involvement and the eye tracking. And what they found is that 12 out of the 13 who were in the high-risk group actually went on to develop autism, and they could determine this by the eye tracking as early as 2 months of age. So let's see how that happens. So if you look over here, an individual with autism is only able to see the entire face. This focus diagram B is someone who has neurotypical development, who soon realizes that the focus has to be in the eyes, or a lot of our communication depends on how we express ourselves through eyes. So look here what happens. This is the individual who is developing autism and is focusing more on the mouth because that's where the sound is coming from, not able to determine that eye tracking and communication is from here and doesn't make eye contact. Of course, there's a complex circuitry for that, but we're not really going to go into that at this point in time. Similarly, here, when you have the individual on the spectrum, they're always looking at places apart from the eye and more closer to the mouth, vis-a-vis a neurotypical who is making eye contact over here. And here, there's an intense conversation going on where you find that the individual on the ASD spectrum is actually alternating between the two people speaking in the lower half of the face, right? Whereas the neurotypical child is looking at all three eyes and is able to sustain that eye contact, which this individual with autism is not able to do. Which is why eye tracking is actually emerging as a very strong clinical biomarker of autism. And in the coming years, I hear there's going to be some sort of a test or a machine which is going to tell us whether this eye tracking, just like a developmental milestone. So the pediatricians are probably going to be checking that periodically, or we are going to be able to see a certain gaze pattern, which all of us will learn, and we'll be able to state whether the individual has a high risk for developing autism or not. So I think all of us can try and see when we have high-risk siblings of anybody diagnosed with autism. And I'm hoping that most of you who work in child psychiatry actually call the sibling back and assess them, because the risk is always there. If you don't, it's a good practice to start doing it now and watch for the eye gaze patterns and see if there is any aberrance in that, which will give you a very early sign about whether that particular kid has a risk for developing ASD or not. Right? Now, here is the most simplistic thing that I could explain in terms of the circuitry, but there is a correlation between emotional recognition, including eye recognition and the amygdala size. And we find that in children who have autism, there is a rapid growth of the amygdala. It was thought to be one of the path-breaking theories initially in autism, but we don't consider that to be the only thing which is involved. What we do know is most children with autism would have a slightly larger size amygdala, and their fear response as well as the emotional response is blunted. It is not actually increased as some people think it should be with that increased size. So this is something which we have to keep in mind in case we ever do imaging or we do a PET for them, right? So that brings us to our next case. Again, please remember, once you read the case, start answering in the chat box so that we can proceed ahead. Saksham is a 12-year-old brought to the child guidance clinic with primary symptoms of eye contact, reduced eye contact, and social interactions. He has constant rocking movements and a fascination with chairs and stools. In the OPD too, he runs around the place and lines up all the stools like a long train. His mother claims that their home is also lined up with furniture in long queues. He gets very disturbed if that sequence was not maintained. Since he was a neonate, his mother reports that he never slept through the night. He would be up every 1.5 to 2 hours, play for about an hour, then sleep again. And this pattern still exists. So we were really shocked to hear this. And I asked her that, you mean to tell me that in 12 years, you've never slept for 6 to 7 hours at a stretch? And she's like, not really. I mean, we used to take turns, but somehow both of us usually get up. So only now he would get up at night and line everything in the home for about 2 hours, and then he goes to sleep again. So typically he gets up at around 2:30 until about 4:30 in the morning. He lines up everything in his house to his satisfaction. And then again, he goes to sleep at around 4 o'clock in the morning. This impacts his entire schedule and the parents' schedule too. Of late, he started getting a bit agitated, but this is very, very occasional. The mother is at her wit's end about what to do. She does report history of being a light sleeper all her life too, and having insomnia through most of her pregnancy. How would you think you would like to approach this? Oh. I can't see that chat box again for some reason.
No answers as yet. Melatonin syrup, Siddhartha has said.
I actually pressed the wrong slide. Okay. Why melatonin, Siddharth? Is sleep cycle correction. Okay. Does melatonin work well in autism? Clonidine or melatonin can be considered. Very good. What else? How does melatonin impact risperidone? Okay. How do all these work in autism? Why are we so interested in? What if he just has a sleep cycle which is aberrant? Okay. What doses will you use? Occupational therapy, sleep improving techniques, so non-pharmacological. Okay. If you have to give medication, what doses will you like to use? Anybody? Three milligrams of melatonin. Okay. At what age? Not sure about age. What happens if we leave this child untouched? Let's say that we do not intervene at all and we assume that this is how the sleep cycle is. After all, the mother also said, no, she was a light sleeper. She had insomnia through her pregnancy. What if we just don't do anything? Do you think that's possible? Should we leave without intervention? So intervention is very important. Now let's try and can worsen his symptoms. Okay. What else can it worsen apart from symptoms? Caregiver burden? Yes, absolutely. But what about the child himself? What does sleep do? Why is sleep so important? Why is a regular sleep cycle so important? Growth. Yes, absolutely. Absolutely. So reduce growth hormone. Absolutely. So basically, autism and sleep is a very complex phenomenon, right? We have a lot of people with autism on the spectrum who tend to have issues with sleep. And this could be because of sensory issues, genetic factors, lack of melatonin, like we discussed, comorbid issues, and gastrointestinal issues, or the gut microbiome, as now we discuss a lot. So they may not have only insomnia. It may manifest as restless leg, it may manifest as a parasomnia, it may manifest as less REM sleep, so on and so forth. It is imperative for us to also understand that the maternal melatonin becomes a very, very important part in neurodevelopment. Because whenever we have a good supply of melatonin and where the mother is sleeping well during pregnancy, and this makes me go back to our old ancient ways of taking care of a mother during pregnancy. So this actually reduces the entire CNS vulnerability, and it induces neuroprotection and works towards normal neural development, which actually gets hampered and makes the individual move towards neurodivergence, which I think nowadays we are seeing so much more emerging, and we keep questioning ourselves that why are the numbers increasing so much? Why? One of the possible reasons is that in general, maternal health is not focused so much upon, and the impact of lack of sleep or the impact of certain things which we considered as norms otherwise. So lack of sleep, not only in mothers, in everybody, because we are all constantly catching up with things on to do, either working or on our phones or social media or whatever. So overall, as a species, our sleep has reduced. Now, until the body learns to change itself to cope with that, probably this is going to be the bridge period while this happens. And what we also see is that it therefore affects the phenotype, plasticity, as well as genetic mutations which can occur. And melatonin intervention even as early as pregnancy. So again, I keep harping on this, that according to me, perinatal mental health is the thing which is going to really come up in a very big way in the next decade. And managing that perinatal mental health is going to be really, really important from a neurobiological point of view, not from an interventional or a pharmacological interventional point of view, but to understand what is happening in utero along with what happens outside. So this circadian disruption, which happens because of the pre and the perinatal problems, can cause alteration in the entire immune pathway, can activate neuroinflammation, and we can have disrupted melatonin synthesis, which causes sleep issues, problems with metabolic synthesis of processes, and altered neurogenesis, which leads to the spectrum as we are seeing it again and again and again, right? And this is what I mean when I say that there has been a sea change in what we are perceiving as environment. Because if you look here, we have this exposome, which includes lifestyle, ecosystems, where we are finding microplastics even in breast milk today, fish, the environment everywhere. The social milieu has changed. Then there is a lot of stress at a cellular level and mitochondrial impairment, which occurs. So the combination of this can actually lead to a variety of disorders, and therefore we are getting trajectories which are moving towards you have in the entire oncology spectrum, B, you have the entire autoimmune spectrum, and C, you have the developmental or the disordered developmental system. And this is what we are actually looking at today when we see all these changes happening. So melatonin, just to jog our memories, is of course derived from tryptophan. And here you see that serotonin is maintained in the cell during the daytime, and melatonin is what is active at night. So melatonin for children with neurodevelopmental disorders has definitely been evidenced to be superior to placebo, has very mild side effects, and is recommended for this population. And like Tony answered, you can also add clonidine or trazodone if you don't really get a response with melatonin. We've had 1 or 2 patients whom we have started on lamborexant because they have, which is not really indicated age-wise for children yet, but they had such severe sleep problems and they were not responding to anything, and they've actually responded very well to lamborexant. So I don't have evidence, which is why I've not put it forward today, and I would not encourage you to really try it upfront unless you're very clear about the fact that you've exhausted everything else. But I just wanted to mention it, but I'm hoping that more evidence comes up for that too, right? So the dosing that we usually stick to, but first let's remember that the half-life is about 20 to 40 minutes and it peaks in about 1 hour. So you need to titrate the timing accordingly, and the levels go down in about 4 to 8 hours. So if someone is really having problems with their sleep and it's very fragmented, then it's okay to give it, maybe say if the child wants to sleep at 9 o'clock, to give it at 9, expect by 10 o'clock the child to go to bed. And if the child is again going to get up at around 2, 3, you can give another tablet at that time so that we don't have too much of a disrupted sleep cycle. And the doses that we usually advocate, so are 1 to 2 milligrams at about 5 years of age and below, 1 to 3 milligrams at 6 to 12 years, and over 13 years. You can change the dosing according to what you think the child needs. You can start with 5 milligrams. Fortunately, today there is syrup available and there are gummies available, and the gummies are quite decently flavored, so the children are happy to chew them and take them, and it's not so much of a struggle as we had earlier, because we used to have to crush it and give it with honey. But melatonin definitely works, so that is something which you can think of working, and I'm happy to note that many of you did answer that. So melatonin also works in therapies. So one of the commonest thing that we advocate in children who are not able to sleep is a weighted jacket at night. And interestingly, the deep pressure stimulation actually stimulates both melatonin and serotonin, and it downregulates cortisol, which is what we don't want when we are sleeping, because as you know, cortisol is more of an activating hormone, and it works better to regulate the melatonin. So combination of melatonin syrup, tablet or gummies along with a weighted blanket works really well in these children and puts them to sleep, provided they are in their sensory diet, they're accepting of the weighted blanket. So sometimes you need to really work around how you want to put that blanket. You want to line it with something else. You want to have some other surface, one layer below it, so on and so forth. So you'd have to play around that. We have a lot of children who also like to have a warm bath, which also increases the tryptophan. Most of the autistic children are not too happy having warm milk. Again, natural tryptophan increaser. But a blanket and melatonin gummies or a warm bath usually works very well. So most of us think that melatonin is beneficial only to sleep, but actually melatonin helps improve not only sleep, but it reduces the anxiety, it improves gut motility and abdominal pain. So it's helpful in colicky children as well. And it also probably protects against brain inflammation, which is why it works so well in autism, because you have a combination of these factors which are usually working in most children, particularly the gut microbiome. I have realized after using melatonin, it takes a while to act. So you might see the change occurring in a few months, but in those few months, you would find an overall change in the child's behavior, appetite, responsiveness, so on and so forth. You may not have a tremendous increase in the core symptoms, because for that you need therapies, but this aids that. Okay. So we go on to our next case. Again, reminder, please put in your answers in the chat box. So Mohan was a 12-year-old boy attending a special school, brought for aggressive behavior since 1 year, multiple episodes of retching and vomiting since 5 days, repeatedly touching his genitalia and touching others inappropriately since 15 days. In the past, he had been diagnosed with very childhood onset psychosis versus ASD, and he had borderline intellectual functioning. His developmental milestones all showed mild delay, though his birth history was unremarkable. His parents separated when he was about 6 years old, apparently because of him largely. He had been diagnosed as ADHD with BIF in 2018. Sorry, that should be 19, not 29. And started on risperidone, atomoxetine, sertraline, oxcarbazepine, and trihexyphenidyl. A lot of medication because his behavior was really difficult to control. Subsequently, the father took custody of the child, and since 2020, he was treated in Mumbai with us. He then had repeated hand washing, and a trial of fluvoxamine was given with methylphenidate along with risperidone. Subsequently, his behavior really worsened. He developed EPR with risperidone, olanzapine did not work, and therefore clozapine was initiated. His ASD workup was also done, and a certificate was generated for him for the same, because he used to go to a special school. His behavior continued to worsen, and trials of naltrexone, sodium valproate, the works were, everything was tried with no significant improvement. His fourth admission this time, and he was tried on clozapine, 125 with minimal improvement. We could not escalate the dose further because he got severe constipation. What do you want to do next? How do we really, and we do get, all of us do get cases like this where you're at your wit's end because you've tried everything in terms of pharmacological as well as non-pharmacological. I haven't outlined too much over here in this case, but he's done his rounds of occupational therapy, speech therapy. They attempted to teach him non-verbal, but no real change. Aripiprazole, haloperidol. Okay. So he developed EPR with risperidone. So haloperidol, we had given him SOS, but we were a little worried because he did develop EPS with that too. Anybody else? Clonidine. Why, Aloki, why clonidine? What is the rationale behind clonidine? Lithium, we tried that too. He did not tolerate lithium. He got a lot of, for his behavioral issues, yes, but why, how do you think clonidine will work? Sorry, Jaram, I should have mentioned we did try lithium, but he could not tolerate it.
Okay.
He developed severe tremors with that. His very long, winding history. I mean, everything under the sun possibly we tried. Okay, anyone else? Anyone wants to attempt any more? Anything you want to throw in? EG for what, Gayatri? He was put on oxcarbazepine when he started. No, there were no, I mean, at one given point in time, we tried to mobilize an autoimmune panel, but it was too expensive and they were absolutely not affording. Prazosin, Lonanserine, okay. So I'm going to tell you what we did. What we did is we actually tried memantine in addition to clozapine. It was introduced and titrated from 5 to 20 milligrams. And within 8 weeks of the same, we saw changes in his aggression. There were rocking and disinhibited movements that he had earlier had significantly reduced, and his sitting tolerance had increased. And it was, honestly, I think it was the first time that we, even the parents had seen this kind of a change in the child. Not to say that he is anywhere close to even being what they would accept at home, because he still has aggressive outbursts. He still has his moments where he is not doing all right. But compared to what he was earlier, he is better. Unfortunately, with this kid, his immunity has always been an issue. And every time we kind of jump one hurdle and we think we have made a breakthrough with him. So with clozapine, what happened is that he went into neutropenia, which was very severe, about 1,500, and we had to admit him on the medical side. And today, he's back with us where we've had to reintroduce olanzapine. We cannot give him clozapine. We can't take that risk. And memantine. So probably the next time that I talk about this, maybe if any of you can jog my memory, then I will tell you about the follow-up of this case. But the memantine really, really did help him. So I also think that panel that y'all are talking about, and an overall screening is required for him, because he has episodes where he has vomiting. There was once when he had Mallory-Weiss stare, and so on and so forth. So, both the psychiatric symptoms as well as his other medical symptoms, he just keeps waxing and waning. And he's always in and out of the hospital for whatever reason. But at least we've understood something that has made a difference to him. And do we really give memantine to children? Because in our heads, memantine is always something which is associated with a cognitive disorder. But glutamatergic dysfunction has been implicated in ASD, and therefore memantine trials are being tried for ASD, though we do need more robust data. And if you look at the NMDA receptor site and you see what is going on over there, so you would find, almost all our drugs have some sort of action there, and all our illnesses have some sort of an interaction at this site. So now you're finding magnesium binding agents coming about. You have ketamine and the dissociative anesthesia, which also explains a lot of how dissociation may be occurring. So the NMDA receptor site is what shall we say, a hub for much research in the coming years. And there is evidence emerging of benefits in ASD. And what happened with our child is that we had benefits in the social interaction, in the behavioral symptoms, as well as in stereotypic behaviors. His language had not really developed ever, so we couldn't test language and memory. But overall, there was the calming, and the caregiver burden had certainly gone down. We're dealing with some other medical issue now. We're just back from the intensive care unit, but at least they, for the first time, I think in their lives, they feel that there is some hope somewhere of something working. And what is going to be interesting for us to follow up and see is whether this child will respond better to therapy now that we have been able to control some amount of the core symptoms. And for those of you who ever thought that there is a component of OCD, so we know memantine is used in adult OCD, and we are trying to see if RCTs can be done for children. But as you know, research in children is a lot more difficult, a lot more taxing even to get ethics approval for. But possibly this is also something which is emerging, right? So when we look at the ASD medication overview, whenever you have ADHD-like symptoms, you can try clonidine. We don't have guanfacine, of course. Atomoxetine and the psychostimulants. Personally, I don't think psychostimulants work so well in this particular population. Whenever there's aggression, self-injurious behavior, you look towards the antipsychotics, of course, stereotypy, we look at SSRIs, and when there is social behavior deficits, and this is not restricted to ASD, though I've put it up here, social behavior deficits actually cross across the neurodevelopmental spectrum. So you'll find it in ID, you'll find it in SLD, you'll find it with ADHD, you'll find it across all the developmental disorders, and you will find it even in schizophrenia, bipolar, and that's where possibly the cholinesterase inhibitors, which I don't have too much experience with in these areas, and memantine, which for us was new learning here, which is why I introduced it too in the talk today, is something which we are going to be looking at and possibly waiting for more evidence to really build up rather than just the anecdotal ones that we have. Some small studies done with a smaller sample size are there, right? And this brings us to the last case of the day. So Jairam, you can definitely catch your flight. Kritika is a 24-year-old who came to the OPD to seek help. She always found it difficult to connect with people around her. Even in school, she remembers sitting alone, as she was never taken in any group. She was good in reading and writing and prolific in math. She was always engrossed in her studies. Now, after having completed her studies in computer basics, she started working in a software firm, which does not involve too much interaction with others, as she has to create complex algorithms, which she's good at. She spoke about her difficulty in social interaction, which she has had since childhood. She also confided that she isn't sure about how she feels about her gender and her strong feelings for her colleague. She has never been in any relationship, but experiences a strong desire to be with her female colleagues. She feels it is somewhat unconventional and feels she is socially inept and sexually different. What do you think is happening to Kritika, and how do we approach this? Please use the chat box for your answers. Anybody? What is happening to Kritika? gender dysphoria, high functioning autism, high prevalence of gender dysphoria. Excellent. Anybody else? GDB, okay. Is it gender dysphoria? What is it then? What do you think Kritika has? Is there something wrong with her? So the high functioning autism, is everyone okay with? Or do we have any doubts about that? Are we all on the same page as far as that is concerned? I'm going to take Siddharth's answer as yes, as everybody's yes for now. Okay. Okay. So now what she's feeling about her sexuality. Let's focus on that. Nothing wrong regarding sexuality, but she says, right. So orientation, is it really a gender identity disorder? So we're not sure, right? So what would we want to do? How would we want to ensure that is this gender dysphoria? Is it sexual orientation, which is towards the same gender? Is it an identity disorder? What would you want to do? How would you help Kritika? Anybody? How can we help her? Yes, explore her identity. All right, so let's go in a stepwise fashion and understand what we're dealing with first, right? And this is very often what happens with people on the spectrum, because they get very overwhelmed with the fact that they have a sexual change which occurs, more importantly, and then when it appears to be aberrant according to what they are trying to follow is a social norm, which anyways is difficult for them, it's more overwhelming. And gender orientation or identity seems to be a spectrum which overlaps to some extent with the autism spectrum. So very often people with autism have gender diverse orientation or gender diverse likes too. And this sexual diversity is someone who they are more likely to adopt different norms towards gender and sexuality and identify as non-heterosexual. Many of them are asexual, in fact. And they have absolutely no interest in sexuality, which they realize a little later. But it does cause a certain degree of distress to understand that we are different. And at times, many of them are polyamorous because there's no real emotion attached to it. So they understand that sex is a basic drive and I have to fulfill that drive. And therefore, it doesn't matter whom I have sex with. So this is also, I wouldn't say asexual, but there is no emotion attached with that particular relationship. Further, when research has been done and numbers actually have to be found out, so about 4 to 9% of people on the ASD spectrum turn out to be gender diverse or transgender, and one in three of them report that they have identity issues. More importantly, when trans individuals were assessed for autistic traits, 3 to 6 times more autistic traits were found in them. So obviously there is some commonality in both the spectrum, which requires a little more looking into. So what do we really do for Kritika? Just like our esteemed chairperson said, we really need to explore what the identity is. So you take as long as you want to obtain a detailed history and establish the rapport, so that there is that confidence, and it takes time with adults who are on the spectrum and high functioning. Simulate interactions with both sexes or genders to judge what are the pheromone reactions. So when you tell someone on the spectrum that you're going to have a sort of a chemical reaction, your body is going to have a reaction, they're actually very receptive to it, which is why you can explain this to someone who is particularly high functioning on the ASD spectrum, sometimes even more than a neurotypical person. Similarly, simulate digital and virtual interactions, and they being so obsessive and so ritualistic. If you tell them that I want you to do 5 digital stimulations in a week or 2 per day or so on and so forth, you will get a detailed account of exactly what happened. Once a certain, explain the concept of what is gender identity orientation and use social stories. Why is it important to use social stories? Because understanding boundaries of an adult relationship becomes a challenge for them, and therefore preempting these scenarios. If you do this, someone may respond like this. If someone responds like this, these are the things which you can do. And if you respond in this particular way, you may offend the person. So we actually need to pre-program the social responses that they have in order for this individual to understand what is the identity or what is the orientation. So it's a very slow process which we have to break down into bits and pieces, like everything else that we do in autism, right? So let's have a quick recap of what we have really learned today. Tell me, what did we learn in case 1? Please type your answers. Case 1 was Mr. Batley Boy, who was the father who came to us. What did we learn? Yes, the autism endophenotype. Very good. Family history is important. So give yourselves a pat on the back. That's absolutely right. What about case 2? Case 2 was the boy who had a sibling who was, I shouldn't say an accident, but very often the parents will tell you. So eye tracking, Shriparno, is what? Eye tracking is what? What about eye tracking? Correct. Early. So one of the earliest clinical biomarkers, and at what age? Do we remember? 2 to 6 months. Excellent. Excellent. So eye tracking at 2 to 6 months is one of the early clinical biomarkers which we can start looking towards. Case 3. It was the boy who was, yes, sleep was the issue. Very good. And what is useful is melatonin, which is very good for sleep. We have it available in various forms nowadays, and the doses we discussed. You can repeat the dose in the middle of the night if required, right? Yes. And case 4. Case 4 was the difficult case where there was a comorbidity. We had tried lots of medications, but this child's behavior was not really improving. And what helped? Absolutely. Excellent. So memantine really helped and can be tried in difficult cases wherever we find that we are really reaching a plateau, and there are more side effects which are really being encountered more than anything else, right? Okay, and the final case. What did we learn in the final case? Two different types of spectrums, right? So what was it about, Kritika? Transgender issues. And so the 2 spectrums often overlap, and we have to be vigilant for it. And when you're dealing with someone who has high functioning autism, then it may take its own time for them to explore their identity and orientation, and for you too. And as I always say, autism needs to be handled with a great heart along with a head. Thank you so much. I'd be happy to take questions, and I must acknowledge slides. Go for these slides. Over to the chairperson and to Rashmi.
Thank you, Alka. I would like to actually thank Rashmin for asking me to chair this, because it was absolutely a masterclass in the way you presented. Firstly, I actually want all of you to note the way she presented, because the topic was recent advances, and Alka presented the recent advances without, all the background which we often, do clutter our presentations with. And all the six patients which you, how many? Six, yeah. Patients the cases which you described have very, very important messages. So just let me recap the way I see it. I think the broad endophenotype is critical, because often in our management, we get frustrated why the parents are not picking up our messages, and why are they asking the same question again and again, and why are they would minutely question our decisions to medicate, because they have a lot of worry about medication. So I think being aware of broad endophenotype is critically important. The other thing, in the last Krutika's situation, we have to acknowledge the fact that there are more adults with autism than children. So, and as we are becoming a more mental health aware society, situations or women or men like Krutika will come out and seek our help and ask for explanations. So I think, again, it's incredibly important to be aware of all the dimensions of a person's existence. And often we are not trained to think in ways of sexuality with our patients, and often we are not comfortable. So I think this is, again, an incredibly important message which I want all of us to remember also. So thank you for doing that. Regarding the how early, I would just like to point out that a very dear colleague of ours, Bhishyadev Chakravarti, has done a lot of research on this. Is someone who is now in Reading and does a lot of work with us in Kolkata, and also he's developed an app with Sangat, which they are trying to try out in Delhi regarding eye tracking. So do look up Bhishyadev Chakravarti's work in eye tracking. The melatonin part was a revelation for me. Thank you. I will need to read more about that and find out more. I think, again, it's an interesting area. The very difficult child who clozapine did not work, and memantine, that's also a lesson for all of us, that we need to be more aware about the role of NMDA receptor in management. So I think overall it was, absolutely star performance. So thank you for that. Any other questions, comments, which Rush?
Thank you so much. Actually, we have to thank our patients. They
No,
teach us
true.
so much.
No, absolutely.
They really teach us so much.
So there's this question about some kids get gut symptoms improve with, right? So yeah, some said kids with gut symptoms improved with GFCF diet. So
yeah, but
Himanshu,
all of them. That's what I typed in this thing. There are some syndromic autism children who would be having either a metabolic profile or mitochondrial disorders. Some of them who have, a comorbidity, which usually we don't explore and go into. Some of them respond to diets. It's not that they don't, but all of them don't respond. So as a blanket statement, we cannot say that, use a GFCF diet for anyone with autism. It's not really worked in that way. And I'm sure that Dr. Jairam can also contribute to this.
Yeah, I agree. I think often it can be a very, very prescriptive tool, and many parents really struggle. So we have to be very pragmatic about recommending GFCF diet. And it
Again,
cannot be applied as a blanket. Yeah.
again, nootropics is the same thing. I don't think psychiatrists really believe in any of those things. This, I'm sorry to say that this is a pediatrician's baby and they love prescribing those more than us. There is a subset of them who do respond, but I think again, those are undiagnosed other disorders. Maybe it is, a metabolic condition, maybe it's a mitochondrial condition, maybe there is a rare genetic syndrome which has been passed on across the ages, which we are not aware of. I don't go too much into genetic testing because sometimes it's a dead end. Well, what do I do after knowing that? And at least in our setup, it's pretty expensive. So honestly, we really don't advocate nootropics at all.
And they're frightfully expensive also.
Rightfully.
Rightfully.
Absolutely. So, yes.
The other thing which I wanted to mention while listening to you, the second child you talked about, how early, there's a lot of actual practical work done by St. John's. Unfortunately, those of you know Professor M.V. Ashok, who sadly passed away earlier this year. But their team has done a lot of very, very, pioneering work in India in early detection. And what one of the things which he had always said, that to liaise with pediatricians, if you are working in if you are working in large hospitals or in your neighborhood, because often pediatricians are quite good in referring children, and if you educate them, then we can pick it up early, which we in Kolkata now get a lot of referrals before the age of 18 months in last 5 years, even 7, 8 months, 10 months, 12 months. A lot of people are coming referred by pediatricians. So I think that is an area to explore.
It's really good. That's really good because early intervention can make a world of a difference.
Yeah.
So I think
I think I just wanted to mention another thing which I think it is very important for all the postgraduates to accept, that there was this apparent nihilism about autism, but I think over the years, while all of us who have been working with this population, so much positive change can happen. And it is not cliche. We have seen young people do wonders. And I think that is something very important to hold on to, because earlier this whole diagnosis of autism would bring in such doom and gloom. So I think we need to imbibe the spirit that a huge amount of change can happen over a number of years. Indeed, it is a difficult path. And if we accept that fact within ourselves, our transactions with families will be a lot more positive. So I think that is also something which I wanted to highlight.
Yeah, absolutely. No, I was just being conscious of your need to catch a flight. So
no, true. No, we will finish. Yeah. Okay. Rashmin, any final comments?
Yes. What can I say? Everything worth being said has already been spoken. And it was, like you rightly said, Dr. Ram, it was very, very enlightening and truly a masterclass, and truly in the right spirit of postgraduate training, right, in the form of cases. So it is so much more relatable, not just to postgraduate students, but even us old foggies. So in that sense, it's what we see as opposed to a typical didactic talk where everybody is just preaching to us. This was very relatable, and kudos to Alka for again doing an exemplary job. But then that's the least we expect from you. So you did not disappoint, but you kind of lived up to what we wanted from you. Thank you once again, Alka. And thank you, Dr. Ram, for making the time for us. And we hope to have you back now on this forum, probably as a speaker in the next few months. And we'll flip the roles then. We'll ask Alka to chair the session. So it'll be
I
fun
would be
thing to
very
do,
happy
right?
to. I would be
Yeah,
very
it'll be a
happy
fun thing to do.
to.
But great, thank you very much,
Thank
both of
you.
you, and thank you all for being with us this evening and continuing to support this lecture series, which is intended to keep the spirit of learning alive, not just amongst postgraduate students, but also amongst consultants, because learning is not something that ends with your post graduation, right? So we want to keep that spirit alive, and of course, without the participants, without the enthusiastic postgraduate students who not only attend these questions, these forums, but also post very interesting questions which are thought provoking and tell us that they are quite in the groove, as the young kids like to say. So it's really nice to see the younger lot being so enthusiastic. And of course, the unflinching support from Sun Pharma for supporting this academic activity. And we promise to continue to bring you interesting lectures in the future as well. And it was great to have the both of you, Alka and Jay. And
Thank
I
you.
wish you all a great evening ahead. Thank you so
Thank
much.
you.
So
Thanks,
much.
Alka.
Thank you. Thank
Thank
you.
Bye bye. Bye.
Thank you both very much. And thank you to the audience too. Jairam, have a very safe flight.
Thank you. Bye. Bye.
Bye
Bye.
bye.